Hello, Padawans. How are you? This is Dr. Malik Rahim, and I'm going to do a quick video on the organization of the DSM-5 TR. I know we didn't get much time in course to talk about that, but I want to talk about it briefly here. Um, when most people think of the DSM, they think of diagnosis, labels, categories, and disorders. But the DSM is a lot more than a list of mental illnesses. It is a carefully organized clinical document that reflects how psychiatric and psychiatry understands distress, dysfunction, and the differences. So, briefly in this video, what we're going to do is we're going to explore how the DSM-5 TR is organized, why that organization matters for clinical practice, and probably most importantly, the difference between what are F codes and Z codes, which is often misunderstood by young Padawans and even practicing clinicians. So this understanding is essential not only for diagnosis, but for ethical practices and for case conceptualization, documentation, and for advocacy. So let's first talk about what is the DSM-5 TR. The DSM-5 TR, or the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text reserve, revised, is published by the American Psychiatric Association. The TR in the title indicates a text revision, meaning that the diagnostic criteria largely remain the same as the DSM-5, but language, examples, prevalence data, and cultural considerations were updated, especially around race, culture, suicide, and emerging research. The DSM-5 TR is used by mental health clinicians, medical providers, insurance companies, researchers, and the courts and legal system. So how it is organized carries real power and real consequences. So the overall structure of the DSM-5 TR is organized into three major sections, followed by the appendices. Section 1, the DSM-5 TR basics. This section explains how to use the manual, cautions against misuse, the limits of diagnosis, the importance of clinical judgment, and it emphasizes that diagnosis is not the same as identity and that symptoms must be understood within cultural and contextual frameworks. This is where this DSM explicitly reminds clinicians. A diagnosis does not capture the full complexity of a human being. In section 2, the diagnostic criteria and codes. This is the core of the manual and what most people think of when they hear DSM. Disorders are organized developmentally, not alphabetically. That means conditions typically diagnosed earlier in life appear earlier in the manual, such as neurodivergent disorders or neurodevelopmental disorders. While conditions are commonly diagnosed in adulthood and appear later, such as depressive disorders, trauma and stress-related disorders, and even personality disorders, this structure reflects lifespan approach, encouraging clinicians to think about the onset, progression, context, and developmental timing. Each disorder includes the diagnostic criteria, specifiers, severity levels, associated features, cultural considerations, and differential diagnosis. And this is where F codes appear. Section 3 in the DSM-5 TR is emerging measures and models. This section includes dimensional assessments, cultural formulation interview, and an alternative model for personality disorders. And importantly, Section 3 acknowledges the DSM is not complete or final. It leaves room for growth, critique, and future revisions. When understanding the diagnostic codes, it's very important to understand why code matters. Every diagnosis in the DSM is paired with a code used for medical records, insurance billing, and treatment documentation. The DSM-5 TR aligns with the ICD-11 and also the ICD-10 coding system used in the United States. There are two major types of codes clinicians must understand: F codes and Z code. They serve very different purposes. So let's first go over F codes, also known as mental disorders. F codes represent diagnosable mental disorders. These are conditions that meet full DSM diagnostic criteria, are considered mental health disorders, and can typically be billed to insurance. Examples including, but not limited to, major depressive disorders, post-traumatic stress disorders, schizophrenia, bipolar 1 and 2, anxiety disorders. Those are examples of F codes. I mean, Z codes, excuse me. Yes, F codes. They medically justify medical necessity, are often required for reimbursement, are used in treatment planning and progress notes. However, this is critical. Having an SF code does not explain why the distress exists. An F code describes what symptoms are present, not things like structural oppression, racism, poverty, housing instability, immigration stress, community violence. This is where Z codes become essential. Okay. Z codes include the context, stressors, and life circumstances. Z codes describe factors affecting mental health that are not mental disorders. They capture psychosocial distressors, environmental conditions, relational problems, systemic and contextual issues. And some of the examples include like housing instability, unemployment, academic problems, discrimination or social exclusion, family conflict, and even legal involvement. Z codes do not diagnose a person. They describe what is happening around a person. This distinction matters deeply. A person may be experiencing depression because of an eviction, anxiety because of racism, trauma because of community violence. Z codes allow clinicians to document where the problem is not located solely within the individual. F codes versus Z codes. Let's be clear. F codes equal disorders. Z codes equal context. F codes answer what symptoms meet diagnostic criteria. Z codes answer what life conditions are impacting this person's mental health. Ethical, cultural responsible practices requires both. Over-reliance on F codes alone risks pathologizing survival responses, ignoring systemic harm, and reinforcing deficit-based narrative. Z codes help clinicians advocate for clients, strengthen case conceptualization, ground treatment in reality, and resist over medicalizing things. Okay. So, in closing, the DSM-5 TR is not just a diagnostic manual, it is a reflection of how society decides what counts as illness, what counts as context, and who carries the burden of explanation. Understanding this organization, and especially the difference between F and Z codes, allows clinicians to practice with greater accuracy, greater humility, and greater justice. Diagnosing should never, ever erase context, and context should never be ignored in the name of efficiency. Okay, so that kind of briefly talks about the organization of the DSM-5 TR, and it talks briefly about the F codes and the Z codes. So I look forward to seeing us all in class. And if you have any questions, make sure you bring them to class and we'll discuss.